Healthcare is too expensive. Employers are offsetting costs onto their employees. Who will make health benefits affordable for hardworking Americans and their families? You will. This is the Empowering Plans Podcast, a show dedicated to helping you once again emphasize the benefit in benefit plan. Now prepare to learn, plan, save, and protect with the Phia Group.
Hi, everybody. It's another Empowering Plans with the Phia Group podcast. Today, you've got Ron Peck, Chief Legal Officer of the Phia Group. And with me is the one and only, the Senior VP of Phia Group Consulting, a leader and a mainstay of the Phia Group. Everybody knows her. If you ask Adam, she's the reason people tune in for the webinars. It is the one and only Jen McCormick. Jennifer McCormick, how are you doing?
Oh, Ron, you are too kind. Good morning. How are you doing today? That is a better question. Are you ready for this?
Listen, for this, everything else that's going on, no way. But this is the one thing about which I am excited and definitely ready. And I don't know about being too kind. Sometimes I think I'm not kind enough, but I can't possibly say enough about you, Jen. Look, I'm kind of fired up. I know you are too. This is going to be a fun one, folks. This podcast, it was funny. We were kind of talking, hey, it's our turn to do an episode. What are we going to talk about? And I basically said, look, let's just vent. Let's just vent. There is so much going on right now in our industry between the rules and regulations that are being released, all the media coverage in politics. And there is just so much misunderstanding and people saying things that from the outside looking in, you realize they're just wrong. You're just wrong. And it's one of those things where I know I'm right and I know you're wrong. Usually, I give people the benefit of the doubt and I do some introspection. I say, Ron, what did you miss? But here I'm thinking, I know I'm right and you're missing something here, guys. And the problem is that so many of the issues and mistakes about which I'm speaking now and that we're going to cover today, they don't exist in a vacuum. Many of the political ideologies and laws and rules and regulations that are being passed that impact us and how we do our jobs and provide benefits to people, their foundation, the seed from which they sprout, are these misconceptions and errors. And today, we're going to cover some of that. And hopefully by kind of pulling back the Band-Aid and exposing this festering wound of misconception to the air, maybe we can start the healing process. It's funny, Jen. Years ago, I remember there was an article about the cost of healthcare and about how we need to tackle the cost of healthcare. And that is just a concept or a phrase that I keep hearing over and over and over, right? They talk all the time about Warren Buffett and his quote about how the cost of healthcare is a tapeworm, right? And the tapeworm won. The cost of healthcare. The issue is that when I talk about, let's say we go and get lunch and I say the cost of lunch, you and I know what we're talking about. We're talking about how much do we need to pay as consumers for that lunch. I'm not talking about how much the restaurant had to pay its suppliers for its produce, right? And I'm not talking about the lives of the cows that were slaughtered to make my steak. I understand that conceptually, those are the costs of lunch, right? The cost we all pay. But you and I know what we're really talking about, which is $50 on my Amex, right? That's the cost. And so at least we're on the same page. With healthcare, people aren't even on the same page. With healthcare, when they talk about the cost of healthcare, some people are talking about the actual price of the healthcare. Same as the cost of the steak. You and I, when we talk about the cost of healthcare, Jen, we're talking about how much is the provider charging for the service, that service being healthcare? Because shame on us, I hear the price of healthcare and I think, how much does the healthcare cost, right? Who's paying what portion of that price and whether, how it's calculated, irrelevant. To me, ultimately it comes down to the price of healthcare is the cost of the healthcare. When people in general talk about the cost of healthcare, in the media, in politics, at the kitchen table, Thanksgiving, with the family, what are they talking about? They're not talking about the cost of healthcare. Oh, they'll call it the cost of healthcare, but what are they really talking about? The cost of insurance. That's what they're talking about, right? The cost of my copay, my deductible, my premium. How much am I paying for the thing that in turn pays for the healthcare? Because most people, they don't think that they're paying for healthcare. That's what's so funny. Everybody's upset about the cost of healthcare, but nobody actually thinks they're paying for it. What people think they're paying for is insurance. And then it's insurance that pays for healthcare. But therein lies the rub. And this is one of my biggest concerns, and we're kind of sort of bringing it into the topic du jour, right? The No Surprises Act. I hear in the media and in these articles about how the intent, right? The politicians say the intent of the No Surprises Act is to protect the patient against balance bills, right? And not just balance bills, but surprise balance bills. These balance bills that no one in their right mind should expect to receive, right? I mean, if you go and you get, something that's excluded from the plan, right? Like cosmetic surgery or experimental treatment, right? You know that it's going to be excluded, and therefore you expect to be balance billed. But if you go through the trouble of finding an in-network facility only to be charged a balance by an out-of-network specialist, that's not fair. And I agree. The origin of these surprise balance bills sicken me too, right? Emergencies where I don't have the ability to choose, out-of-network specialists at an in-network facility, air ambulance that refuses to contract with anyone. I get it. But this idea that by forcing the plan to deal with it, forcing the insurance to deal with it, the patient does not pay the cost, does not pay the balance, is wrong. It's just wrong. The reason why when a person has a fender bender on a side road, they get out, they look at the damage, and if the two drivers agree, they say, hey, look, let me just pay you something. We don't have to report this to the insurance. Auto insurance. Oh, I don't want to file a claim. Let me fix it myself. Let's not tell the insurance. People are so afraid to submit claims to their auto insurance. Why? Because they know when the cost of providing coverage to that person increases, so do their premiums. Yet, with health insurance, every fender bender, every oil change, every window wiper, every gas filler up, we want to submit a claim to the insurance. Because people, for whatever reason, they understand that when the cost paid by their auto insurance goes up, then your premiums will also go up. Don't understand that the same concept applies to health insurance. So when a law like the No Surprises Act is passed that requires the health insurance to pay more to resolve these balance bills, these surprise balance bills, how people think that that's some sort of magic solution, when the truth is all we're doing is kicking the can, right? Because that insurance or that plan is then going to increase the premiums, increase the contributions, increase the copays, the deductibles to offset the cost of paying those balance bills, which means those patients you're protecting, and you can't see Jen, I'm doing like air quotes, protecting, they're still paying. They're paying later, right? They're paying in the form of copays and deductibles and premiums and contributions rather than paying the balance bill itself. You're spreading it over more people. It impacts each individual person less by spreading it over a bigger body of people. I get that. I do. But we as consumers, we as patients are still the ones who pay the cost one way or another. So this doesn't actually address the cost of healthcare. It just addresses who's paying and how we're paying the cost of healthcare. So I just really had to get that off my chest. And the last thing, and I think it really all sort of comes from this one other misunderstanding in general, and then we'll talk a little bit more specificity, Jen, but one of the other things that I read an article last night about how hospitals are not obeying the transparency rules that were recently passed. They're not posting their prices online, and they're more than happy to pay a $300 a day fee, which is nothing to them, right? Just go to the cafeteria, get a cup of coffee and a muffin, and you just paid that hospital's fine for the day, okay? I've unfortunately spent a little too much time in hospitals lately, all right? So I know. In that article, they talk about how, amongst other things, these hospitals are supposed to be posting the prices that they negotiated with insurance. And the reason that sticks in my craw, Jen, is because hospitals don't negotiate prices with insurance. That phrase right there, the price negotiated with insurance, at its core, there's a fallacy there because they don't negotiate prices. They negotiate discounts, 20%, 30%, 40% off. They're not negotiating $1,500 for this, $700 for that. And most people in this country can't understand that because we as consumers, you go to the grocery store, you buy a bunch of bananas, it doesn't say 50% off, whatever the price is, which you'll find out later. No, it says what the price is. Maybe there's a discount, but at least it says what the price is as well. People can't wrap their head around the fact that insurance is agreeing to pay prices it does not yet know. And the only thing we do know is the discount, not the price. So you can't post prices that don't even exist. The best they can do is post average prices and the discount that they agreed upon. But that's not going to tell you anything because the price could change. So, that goes right back again to this complete lack of understanding by these lawmakers, by these decision makers, by people in general, as far as how it all works. And as a result, all of these efforts, admirable as they are, will fail because they don't address the actual issue itself. So speaking of the No Surprises Act and other rules that have recently been passed, I know parity is another one. I know there's some specific issues that we've uncovered in these rules that you wanted to talk about, Jen.
Yeah, and to connect back, one of the things that you posed was that people just can't seem to understand health insurance the same way that they can understand their auto insurance. It just doesn't make sense, right? And I think part of the reason why this is becoming a much larger problem is the motivation. Oftentimes when we need a replacement for a car or need to get something checked or something breaks or there's a fender bender, it's not an emotional experience. But oftentimes we're talking about health insurance, it's very emotional. There are a lot of pieces that are involved. And I think that oftentimes people have a hard time disconnecting from that. And they see it as something that they are entitled to, not something that they must have because of all the emotion that's connected to it. And when we're talking about the provider reimbursement piece and whether someone can actually see the price or someone can actually see the discount, that actually has been one of the things specific to the parity rules that you brought up that has been a huge problem. And there are now rules under the Consolidated Appropriations Act that mandate a plan to disclose and document all of the procedures that they have in place to ensure that their plans and how they are calculating their benefits on the medical surgical side are in parity with the mental health and the substance use disorder side to make sure that all those benefits are being offered in parity. And when they outline those rules requiring those plans to be transparent and put it on the table, they outline their 4 focus areas. And one of the focus areas has actually been the provider reimbursement. They want to see how plans and on an out-of-network basis, how they are actually calculating those payments, what they are doing, what their parameters are to make sure that those are being offered in parity from the mental health and the medical surgical side. And from audits that we've actually seen, a number of audits already so far have really laser focused on that exact area of the plan, looking to see how it is that they are calculating those reimbursement rates. And that is not something that people have had to necessarily explain in detail before. And one of the other things that people oftentimes will hide behind, well, that's what the network does. That's how the network has it set up. So we're in this pickle here. Bind, you also mentioned about how the hospitals aren't posting this. So if the prices aren't being posted, the plans are left to try and figure out how it is that they're making these calculations to pay the providers, but the providers are complaining that what they are receiving from the plans is not enough. Where does that leave us? It leaves with even more confusion, and we don't have that clarification yet from the regulators on how exactly to outline this, not only in our plans, but for the patients and the plan participants, which is going to be snowball into a larger problem because specifically the NSA, these rules are set to go into place as of 1/1/2022, which is short of 6 months away. And the agencies have said that what's out there is what you get. We hope it is our intention to issue some regulations by December 27th. That's our hope. But if we don't, we think there's enough there for you to use your good faith interpretations to figure out how to make these calculations, how you can be in parity with all these regulations, and how you can make sure that you're doing the right thing and offering the transparency and clearing up any of the confusion that exists. And I don't know that there's enough out there for us to really make those good faith, reasonable decisions based on the information and the regulations that we have at this point. Now, and even more specifically, kind of digging into the NSA itself outside of the parity piece, It's talking about the definition of emergency. And you know, Ron, that one of my favorite things to do is to talk with you about plan language, right? It's always such an exciting topic. I can't think of anything better because I want to understand when we're trying to prepare plans and get everyone ready for renewal. What is it that you need to do? What is it that needs to change? What do you need to modify under your current plans to make sure that you are ready and in compliance? And one of the things that is being modified under the NSA is the definition of emergency services. So the big piece about emergency services that is a little bit troubling is that now is going to include some post-stabilization procedures, certain things that weren't necessarily considered to be part of an emergency service prior to that. The other thing is adding this level of subjectivity. So when we are defining plan language, one of the things that we always try to do is to be as clear as possible. We want to make sure that the language in the plan specifically outlines, like the law, what it is that will be covered and what it is that will not be covered. That prevents issues from happening ideally down the road with any other carriers, any other situations, any other confusion. So now, when we're talking about the definition of emergency services and emergency room services, we know that you can't deny a particular service based on the diagnosis without taking into consideration the presenting symptoms for that individual. And also, this is going to require you to not take into consideration any timeframes that may have existed from when the symptoms started and when the patient actually presented to the ER. And things don't have to suddenly happen or suddenly have occurred. So that's going to require us to take a look at the medical records. This is a lot more subjective, and drafting plan language from our side at Phia, but also from the plan administrator side, this is going to require a larger lift in order to make sure that you understand what would and what would not fall under the definition of an emergency service. So this is going to be a big challenge for plans and administrators when it comes to going into effect to make sure that you're doing and covering the right things, because there are a lot of implications, like you said, with whether or not there would be the opportunity for a claim or a benefit to actually be subject to the IDR rules, the open negotiation process, and going through that versus something being an appeal. So this is something we're actually going to have to flush out too and make sure we have some more conversations and hopefully get some additional feedback from the regulators about how it is that we're supposed to do this and how we want to apply this patient level review of all of these factors, but also make it manageable, because this is going to create a huge administrative burden for these TPAs and administrators and plan administrators when it comes to the actual implementation of these rules, something I'm a little bit concerned about. And I don't know, Ron, from your perspective too, about the patients and from the appeals versus the IDR, if you have something that is equally as troubling, but from the appeal process versus the IDR process, it seems like that is something that is left to the imagination at this point. And I know that the regulators did try to outline the different categories of buckets of what would be subject to an appeal and what would be subject to the IDR process. But that gets pretty confusing to me when I'm trying to overlay that with the existing ERISA regulations, the existing ACA regulations, and then to figure out what in the world I'm supposed to do now with these new NSA regulations. It just doesn't make sense to me. I don't know if you have any similar opinions about that.
You know I do. So I think, gosh, was it 10, 15 years ago, we were helping more than one benefit plan that had a PPO network. Okay, so they had a network agreement. But then the plan document, it also limited how much the plan would pay in a given circumstance to sort of this maximum allowable amount. And lo and behold, the network basically said in this agreement that you just take the provider charge, you apply a discount, and then you pay whatever that charge minus the discount is without any other limitation. Meanwhile, you had a stop loss carrier in this case that was telling the plan and the TPA that they need to apply the maximum allowable amount as defined by the plan document, which, like I said, would result in a lesser payment than the amount the network was saying they would have to pay, bill charges minus a discount. And so this plan and this TPA kind of found itself, we like to say, between a rock and a hard place, where do you pay the max allowable under the plan, or do you pay the provider charges minus the discount per the network agreement? And the only argument that we came up with at the time was that the network agreement said that you pay the provider charge minus the discount on eligible services or covered services. Covered services. That was the phrase. Covered services. And our argument at the time was that any amount in excess of the maximum allowable under the plan document was not a covered service. Basically, the definition of a covered service under the network agreement. The network agreement was that it was based on the definition of what's a covered service per the terms of the plan. So that was sort of the tool or the trick we used to say, okay, well, if it's referring to the plan and the plan has this max allowable language, then any charges in excess of the max allowable are not covered services. The response from the provider and response from the network when we made that argument was this. The term covered service refers to whether the service itself, the medical service, in appendectomy, setting a broken bone, right, in x-ray, the nature of the service itself, not the dollar amount, not the price, but the service itself, is it something that's covered or excluded? That was their perspective on a plan and what it means to be covered under a plan. It has nothing to do with the dollar amount. What's payable, what's not, how much is payable, how much is not. That's not what the term covered means to them when it comes to providers and networks discussing what a covered service is. They're just talking about the actual service or product that's being provided regardless of the price, right? Cosmetic surgery, not covered. Appendectomy, covered. You with me? So fast forward to today, and that same mentality is what we're seeing here, Jen, because these regulators are basically saying that the appeal process applies when a claim is denied, presumably because it's not covered. See how I brought it in around, right? But the IDR process, this arbitration under the No Surprises Act, applies when something is covered, but there's a dispute as to how much is payable. My problem is that these regulators think there's this fine distinction, this black and white distinction between what's excluded by the plan and therefore something you would appeal, and what is covered by the plan and there's a dispute over the price. My problem is often there is a dispute over how much is payable, but it's based on the terms of the plan, and frequently it gets resolved through an appeals process. And the example I've been using around the office, Jen, and so I apologize for saying it again, what happens if a claim comes in, it's for a service that the type of service is covered. I keep saying it, an appendectomy, right? Someone went in, they have appendicitis, they got to get it cut out, whoop, appendectomy, it's a covered service, medically necessary, ding, bang, boom, they submit the claim, the TPA gets the claim, the bill is for $8,000 and they pay $800. Well, according to these regulators, the whole No Surprises Act IDR process gets triggered. And we're going to fight over how much is payable, and we're going to take it to arbitration. It's baseball arbitration, and we're going to fight. Prior to the No Surprises Act, if someone had filed an appeal, someone at the TPA would have noticed we forgot a zero on the check. Whoops! Ah! I'll reissue payment. Sorry about that. There's no dispute. These things happen. These are literally clerical mistakes, coding issues. Someone forgot a number on a code somewhere. Someone forgot a decimal point. Someone forgot to add something. These are the types of things that often get filtered out in the appeals process. So how can we in good faith say we know what the balance actually is until we've gone through the appeals process? That's what blows my mind. The whole No Surprises Act and IDR arbitration process is meant to resolve a balance. But until we go through the appeals process, we don't even know what the balance is.
You're exactly right, Ron. And that is why I'm so concerned, is that these appeals that we see have been to resolve both concurrently. So now, if there is a process that we're supposed to follow where there are separate paths, how are we supposed to do it when all of the appeals that we see are being submitted to address both things at the same time?
You know, Jen, I hate to put you on the spot, but I got to ask. You and I just spent a lot of time talking about things that are worrisome. And listen, folks, we're submitting comments. We're participating with industry associations. We're making our voice heard. We're bringing these issues to the attention. And fortunately, we have yet to receive the guidance and release on the IDR process. So some of this may get clarified further. But in the meantime, Jen, we've talked about all these sort of issues and things that plans can't do, or really sort of things to prepare for, but we don't know how. What would you say a TPA or a broker or a stop loss carrier or a plan sponsor, what are some things that they could do now that just make sense from a preparing standpoint, best practices standpoint, regardless of how things ultimately shake out?
Yeah, in summary, what I have learned from the regulations we have just seen in the past 6 months, past year, have been to be audit ready at any time. We know that the audits are coming in more frequently now than they have been ever in the past, and to make sure that you know what your processes are, you know what your protocols require, you know where your documentation is saved, that you have everything in your house ready to go, ready for a DOL auditor to come in and go through that process, because it's not a matter of if it's going to happen, it's a matter of when it's going to happen. So be ready, go through all of the steps to make sure that your plan document is where it needs to be based on the information we know now, that your UR procedures and manuals are in place, the TPA documents are in place, the network credentialing information is all outlined, that you have everything that you need and that you are ready for an audit for when it will happen.
Great advice. So, Jen, I think we've definitely piled enough onto people's plates for today. This is not the end, but only the beginning. As long as people continue to tune into our podcast, stay linked into our social media, our webinars, and we'll continue to bring you the updated news and guidance. And for those who are clients and partners of the Phia Group, you, as always, are the first ones on our mind. We prioritize you, and you're first in the queue. We'll keep you updated. So on behalf of myself, Jen, of course, Pat, the podcast producer, Pat Santos, the man, the myth, the legend in the booth, I assume, and the rest of the Phia Group and industry at large, thank you so much for empowering your plans with the Phia Group. Be well.